Hello, and welcome to this continuing education presentation discussing teen pregnancy prevention, application of CDC's evidence-based contraception guidance. This presentation will provide an overview of the current trends in teen pregnancy and introduce efforts that providers can take to increase access to safe and effective contraception using CDC's evidence-based contraception guidelines. After completing this training, participants will be able to review the trends in teen pregnancy, sexual behavior, and contraceptive use, describe current contraceptive methods available to teens, describe the current evidence-based recommendations about the safety and effectiveness of contraceptive methods for teens, and discuss clinical preventive services to improve outcomes and quality of life. We'll begin with Section 1, Trends in Teen Pregnancy, Sexual Behavior, and Contraceptive Use. There are four major current trends. 1. Pregnancy, birth, and abortion rates are declining in the U.S. for teens aged 15 to 19 years old. 2. Teen birth rates vary by age, race, ethnicity, and state. 3. The U.S. has the highest teen birth rate of any industrialized country. And 4. Teens use less effective methods and use these methods inconsistently. This graph, compiled by the Guttmacher Institute, shows pregnancy, birth, and abortion rates for teens ages 15 to 19 years old in the United States from 1973 through 2011. Overall, pregnancy, birth, and abortion rates for 15 to 19-year-olds are declining, including a 23% decline in pregnancy rates since 2008. Still, in 2011, there were nearly 553,000 pregnancies to teen women for a rate of 52.4 per 1,000 women. Of these pregnancies, 60% ended in birth and 26% ended in abortion. In the U.S., 1 in 4 adolescent girls will become pregnant by age 20. In addition, 2 in 5 black girls and 1 in 3 Hispanic girls will become pregnant by age 20. This graph shows birth rates from preliminary 2015 birth data from the National Center for Health Statistics for females 15 to 19 years old, with additional age breakdowns of 15 to 17 and 18 to 19 years old. The trends show that the birth rate dropped 8% in 2015 from the previous year. Overall, from 2007 to 2015, the teen birth rate has decreased 46%, and from 1991 to 2015, it has decreased 64%. This is a historic low. This graph shows the teen birth rates according to race for females 15 to 19 years old from 2000 through 2015. Here, we can see that the highest rates are among Hispanics, shown in the green line, and blacks, shown in the orange line. However, rates for all races are also at historic lows. In this map of the United States, standardized teen birth rates by state in 2012 are represented by different colors and shades. The states in dark green have the highest standardized teen birth rates of 36 or more per 1,000 women aged 15 to 19 years, while the states in light gray have the lowest standardized rates of 14 to 22.9 teen births per 1,000 women aged 15 to 19 years. Trends in the map show that teen birth rates were lowest in the Northeast and West, and highest across the southern states and Midwest. This graph shows the teen birth rates per 1,000 women aged 15 to 19 years from different countries. All birth rates are for 2013 unless otherwise noted. Although rates have been declining worldwide, the U.S. still has the highest teen birth rate, up to 10 times that of other developed countries. In 2012, there were 29.4 births per 1,000 female teenagers aged 15 to 19 in the U.S., which is a decrease since 2008 when it was 41.5 births. Even so, this is a much higher rate than the highest rate in Europe and the UK at 17.3 births, and almost 10 times the lowest rate in Switzerland. This graph shows the percent of pregnancies that were unintended in the U.S. in 2011, categorized by age. In this same year, 45% of all pregnancies were unintended. However, percentages are highest among younger age groups, with about 3 out of 4 pregnancies being unintended among adolescents aged 19 and younger. Specifically, among adolescents 15 to 17 and 18 to 19 years old, 72% and 76% were unintended respectively. Monitoring trends in teen pregnancy rates are important since teen pregnancy can have many significant consequences for the infant, teen mother, and society as a whole. For infants, the risks of poor neonatal outcomes such as low birth weight, preterm delivery, or neonatal death are more than double the risk for an adult woman. Children of teen mothers are more likely to be subject to abuse and neglect. As many as 60% of those who became pregnant in early or mid-adolescence have a history of childhood sexual or physical abuse, and that cycle also may repeat itself for the child. In addition, infants of teen pregnancies are more likely to be future teen parents themselves. Consequences of teen pregnancy are not only felt by the child but also the teen mother. Teen mothers are more likely to come from poverty and have higher rates of school dropout. In fact, fewer than 2% who give birth before age 18 will graduate from college by age 30. In addition, teen mothers are also at risk for repeat pregnancy, and over 15% of teen births are repeat pregnancies. Society can also feel the effects of teen pregnancies. Teen childbirth costs the U.S. $9.4 billion tax dollars and $2.1 billion in public sector health care in 2010, according to the National Campaign to Prevent Teen Pregnancy. As a result, teen pregnancy prevention is a crucial aspect of adolescent health. Specifically, there are 3 main goals of teen pregnancy prevention. The first is to decrease pregnancies among sexually active female teens. The second is to delay initiation of teen sexual activity. And the third is to increase use of effective contraceptive methods, including long-acting reversible contraceptives, or LARC. Over the next few slides, we will be presenting data describing the current trends in adolescent sexual activity and contraceptive use. The slide contains a graph that shows the percentage of high school students in 2015 who have ever had sexual intercourse by sex and race ethnicity. 41.2% of all high school students surveyed had ever had sexual intercourse. The prevalence of having ever had sexual intercourse was 39.2 among female students and 43.2 among male students. The prevalence of ever having had sexual intercourse was higher among blacks at 48.5% than Hispanics at 42.5%, and higher among Hispanics than whites, who are at 39.9%. This graph shows the percentage of high school students in 2015 who were currently sexually active, defined as having had sexual intercourse with at least one person during the 3 months before the survey. The percentage is also reported by sex and race ethnicity. 30.1% of all high school students surveyed reported current sexual activity. The prevalence of being currently sexually active among female and male students was nearly the same at 29.8 and 30.3% respectively. The prevalence of being currently sexually active was higher among blacks at 33.1% than whites and Hispanics, both at 30.3%. But the magnitude of this difference has decreased since 2011. This graph, with data from the National Survey of Family Growth from 2011 to 2013, shows ever use of contraception among sexually experienced females 15 to 19 years old by contraceptive method. Most sexually experienced female teens have used contraception, with condoms being most frequently reported at 97%, followed by the pill at 54%. Over half of teens, or 60%, have used withdrawal for contraception. Less than 20% have used the more effective injectable, depomedroxyprogesterone, or DMPA, and less than 5% have used the most effective reversible methods, intrauterine devices, or IUDs, or implants. This graph shows use of contraception at first sex among females 15 to 19 years old. Use of contraception at first sex among this population has generally increased between 2002 and 2006 through 2010. Still, only 2/3 have used a condom at first sex, and less than a fifth have used the pill. Messages and programs for adolescents that continue to improve contraceptive use at sexual debut are extremely crucial, since 50% of adolescent pregnancies occur within the first 6 months of coitarchy. However, the percentages of adolescents using a contraceptive at last sex shows a more encouraging picture. 86% of females aged 15 to 19 years old and 93% of males within the same age group have used some form of contraception at their last sexual encounter. The graph on this slide presents data from the National Youth Risk Behavior Survey in 2015 and shows the percentage of high school students who used a condom during last intercourse by sex and race ethnicity. Among the 30.1% of high school students surveyed nationwide who are currently sexually active, 56.9% reported that either they or their partner had used a condom during last sexual intercourse. The prevalence of having used a condom during last sexual intercourse was higher among male students at 61.5% compared to female students at 52%. Additionally, prevalence of use was higher among black students at 63.4% compared to white and Hispanic students at 56.8% and 55.6% respectively. From the previous slides, it is clear that the majority of teens have used contraception at some point. However, the majority are using less effective methods such as condoms or pills, and in an inconsistent pattern. Approximately half of teens who are having sex at a given point in time are not using contraception. Of the teens who are having sex and using contraception, more than half experience contraceptive failure because they are using moderately or less effective methods, such as condoms or pills, and they are using them incorrectly or inconsistently. So even if the adolescent is using contraception, he or she may experience failure of the method itself, or more likely, he or she may not be using the method correctly and consistently. For example, the adolescent may be forgetting to take her pill, or may not be using a condom at each sexual intercourse. Despite the popularity in less effective methods and inconsistent contraceptive use among adolescents, there have been significant declines in adolescent pregnancy rates. From 2007 to 2011, pregnancy rate among adolescents 15 to 19 years old in the U.S. dropped 25%. The majority of this decline is attributed to increased contraceptive use among adolescents. Among those who did not choose to use contraception, it is important to understand why they did not use it. The Pregnancy Risk Assessment Monitoring System collected this information in their survey from 2004 to 2008. The table on this slide reports on this data, describing the reasons that women aged 15 to 19 who recently delivered a live birth from an unintended pregnancy did not use contraception. The most common reason cited was that they thought they could not get pregnant. Almost 25% stated that their partner did not want to use contraception, which likely was a condom. Pregnancy ambivalence was also a common reason. It is also important to remember that abstinence is the most effective way to prevent HIV, other sexually transmitted infections, or STIs, and pregnancy. It should be included in counseling, but not just for teens who have not yet engaged in sexual intercourse, but also as an option for teens who are sexually active, but may not have a reliable method available at a given time. Next, we will be discussing the different contraceptive methods available for adolescents. Objectives for this section are 1. Review data on current use of contraceptive methods in the U.S. 2. Describe the tier system of contraceptive effectiveness. 3. Review the currently available contraceptive methods in the U.S., including dual protection, which is protecting against both pregnancy and STIs. And 4. Highlight the need for more consistent and effective method use. This graph shows us the use of specific method or methods at last intercourse by females aged 15 to 19 years old in 2012. Despite increasing recommendations that adolescents should consider using long-acting reversible contraception or LARC, this graph shows that most adolescents are using the pill or condoms, with 55% using condoms that last intercourse and 35% using the pill. It is also important to note that only 3% are using the most highly effective methods, which include IUDs and implants. This figure shows currently available contraceptive methods ranked by typical effectiveness, meaning how effective is the method at preventing pregnancy with real-world use. Incorrect or inconsistent use can impact the effectiveness of the contraceptive method. In Tier 1 are the most effective methods, with less than one pregnancy occurring per 100 women per year. The most effective reversible methods include implants and IUDs. Tier 2 methods include injectables, pills, patch, vaginal ring, and diaphragm. Failure rates range from 6 to 12%. Tier 3 methods include condoms, withdrawal, sponge, spermicide, and fertility awareness-based methods. Failure rates range from 18 to 28%. The more commonly used methods among teens, the pill and the condom, are listed in the second and third tier respectively. Along with other features of individual contraceptive methods, it is important to highlight typical use failure rates when counseling teens on contraceptive methods. Failure rates during typical use describe the number of pregnancies for the average person who does not always use the method correctly or consistently. This reflects the effectiveness of a method. Failure rates during perfect use are estimated based on consistent, correct use at every act of intercourse. For pills, combined or progestin only, the perfect use failure rate is 0.3%, compared to the typical use failure rate of 9%. The levonorgestrel IUD, a hormonal IUD containing progestin, is not user-dependent like the pill, and therefore has the same perfect use and typical use failure rate of 0.2%. Among 100 couples who use no contraception, it is estimated that 85 will experience a pregnancy in the first year. Typical use estimates for most methods are based on the National Survey of Family Growth. Other estimates were based on previous studies or were extrapolated from similar methods. While Tier 1 includes both permanent methods or sterilization and reversible methods, this talk will focus on reversible methods only. LARCs are highly effective Tier 1 methods that do not impact future fertility and provide easy long-term contraception with typical use failure rates of less than 1%. In the US, LARCs include several levonorgestrel IUDs that vary by inserter, dose of levonorgestrel, and duration of use, in addition to the copper IUD and the etonogestrel implant. LARCs have been growing in popularity among all contraceptive users, including 15 to 19-year-olds. The Institute of Medicine, or IOM, the American Congress of Obstetricians and Gynecologists, ACOG, and the American Academy of Pediatrics, AAP, all recommend LARCs for this at-risk population. These methods are considered easy, highly effective methods since they are not user-dependent, giving them the alternative name, forgettable contraception. The levonorgestrel IUD is one of the LARC methods available to women, and the FDA has recently approved 4 different types of levonorgestrel IUDs in the US. Mirena was approved in 2000. It initially releases 20 micrograms of levonorgestrel daily and is effective for at least 5 years. Skyla was recently approved in 2013. It initially releases 14 micrograms of levonorgestrel and is effective for at least 3 years. Liletta was approved in 2015. Like Mirena, it releases 20 micrograms of levonorgestrel daily. It is currently approved for 3 years. Kyleena is the newest available IUD, approved in 2016. It releases 17.5 micrograms of levonorgestrel daily and is currently approved for 5 years. Since the local effects of levonorgestrel cause an atrophic endometrium, side effects include irregular bleeding for the first 3 to 6 months, followed by lighter bleeding or amenorrhea, and reduced dysmenorrhea. Studies with the 5-year IUD show that it may alleviate heavy bleeding from many causes, including bleeding, diathesis, anticoagulation, fibroids, and adenomyosis. These IUDs do not protect against STIs, and dual protection with condoms should be strongly encouraged. The copper T380A IUD has been FDA approved since the 1980s for 10 years, but studies suggest it is effective for up to 12 years. The most common reason for copper IUD discontinuation is heavier, more painful periods, which may decrease over time. Anticipatory counseling regarding menstrual changes after both IUDs are placed is extremely important and may help with continuation. The copper IUD can also be offered for emergency contraception up to 5 days after unprotected intercourse and is more than 99% effective. The copper IUD does not protect against STIs, and dual protection with condoms should be strongly encouraged. The contraceptive implant containing etonogestrel is another type of LARC available for women and is currently the only contraceptive implant approved in the U.S. since 2006. The implant was updated to Nexplanon in 2011 and is now radio-opaque and has a new inserter. Etonogestrel levels remain stable over 3 years, which leads primarily to anovulation. Similarly to the levonorgestrel IUD, it also acts on the uterus to cause an atrophic endometrium and thickens cervical mucus to block sperm penetration. The effects on the uterine cavity may disrupt menstrual cycles, leading to amenorrhea, irregular bleeding, or infrequent bleeding, and less often, prolonged or frequent bleeding. The contraceptive implant does not protect against STIs, and dual protection with condoms should be strongly encouraged. Despite LARCs being considered the first-line contraceptives for adolescents and highly desirable by many adolescents, there have been many barriers to LARC provision in this population. 2 specific publications surveyed providers to determine why LARCs are not being provided. Providers seem to have concerns for safety, including risk of pelvic inflammatory disease, or PID, and STIs. Unfortunately, this is a common misconception about LARC use. Other common factors for not providing LARC included patient preference, concern about safety for other reasons, not being trained in insertion, and not having IUDs available. Medical barriers due to these myths held by providers as well as patients are just some of the reasons that teens are not accessing effective contraception, especially LARCs. Cost, knowledge, and attitudes are other barriers to LARC use. The Choice Project in St. Louis provided no-cost contraception of a woman's choice to her after listening to a comprehensive educational script about the different methods. Over 60% of teens participating in the project chose the LARC method when knowledge and cost barriers were removed. And the results of the Choice Project showed the astounding benefits of LARC use. There were very significant lower rates of teen pregnancy, births, and abortions among teenagers participating in the Choice Project compared to teenagers in the general U.S. population. This highlights the importance of overcoming the financial and educational barriers when it comes to increasing effective contraceptive use. The next level of contraceptive methods are the Tier 2 methods. The Tier 2 methods include the injectable, DMPA, the pill, both combined and progestin only, the combined hormonal patch, and the combined vaginal ring. These methods have higher typical use failure rates because they require more effort by the user. It is important to note that the most effective method of contraception is the method a woman or couple is most likely to use consistently and correctly. Correct and consistent use helps close the gap between typical use and perfect use. Methods that require more effort by the user have higher typical failure rates because there is more room to not use the method correctly and consistently. Both the pill and condom, which were shown earlier as the most common methods used by teens, are difficult to use correctly and consistently by most users. One study that surveyed 2,000 women nationwide found that 45% of young women aged 18 to 24 using pills missed one or more pills in the last 3 months, and 62% of those using condoms were not using them every time they had sex. Now we will be discussing the various Tier 2 methods, starting with the injectable. Depomedroxyprogesterone acetate, DMPA, Depo, or the shot are all names used for an injectable progestin that is given either intramuscularly or less commonly subcutaneously every 3 months. Due to the larger dose of systemic hormone, effects on ovulation may last up to 9 months. Amenorrhea and irregular bleeding again may be a side effect. In one study of teenagers, almost 2 out of 3 reported amenorrhea at 6 months. DMPA does not protect against STIs, and dual protection with condoms should be strongly encouraged. Contraceptive pills include both combined oral contraceptives, or COCs, and progestin-only pills, or POPs. COCs are generally dosed over a 28-day cycle with 21 active pills and 7 days of placebo. POPs are dosed over a 28-day cycle with 28 active pills and no placebo, and can be useful for women who are breastfeeding or have other conditions that may not make them candidates for safe estrogen use. Extended use of COCs may aid in compliance and can decrease symptoms associated with menses, including heavy menstrual bleeding and dysmenorrhea. Contraceptive pills do not protect against STIs, and dual protection with condoms should be strongly encouraged. The contraceptive patch is another combined hormonal contraceptive containing both estrogen and progestin, which are delivered transdermally. The user applies one new patch and removes the old patch each week for 3 weeks. The last week of the cycle, the user does not use a patch, and this is generally the time of bleeding. The patch does not protect against STIs, and dual protection with condoms should be strongly encouraged. The contraceptive vaginal ring is another combined hormonal contraceptive that delivers estrogen and progestin vaginally. The user places the plastic ring in the vagina and leaves it in place for 3 weeks. It can be removed in the 4th week, at which point bleeding occurs. The ring does not protect against STIs, and dual protection with condoms should be strongly encouraged. When discussing these methods, it is also important to mention the importance of quick start. Quick start refers to the initiation of contraception on any day of the cycle to allow for more reliable and faster protection from unplanned pregnancies, as long as the provider is reasonably certain that the woman is not pregnant. Encourage 7 days of backup contraception, such as condom or abstinence, until method takes effect, which may vary. Quick start initiation may improve short-term continuation of combined oral contraceptives and has not been shown to increase unscheduled bleeding. Thus, the recommendation for initiation of combined hormonal contraceptives, or CHCs, is to use backup or abstain from intercourse for 7 days if the method is initiated greater than 5 days from the start of last menstrual period. The U.S. Selected Practice Recommendations, or USSPR, which will be discussed later in this presentation, provides guidance on how to counsel patients about when to start and when to use backup contraception for all methods. As you can see from this chart, all methods of contraception can be started at any time if the provider is reasonably certain that the woman is not pregnant. Lastly, we will discuss Tier 3 methods. These are examples of Tier 3 methods, or less effective methods. These methods require even more effort by the user and have higher typical failure rates. Correct and consistent use of condoms may be difficult for all ages. Fertility-based methods refer to a range of techniques used to avoid the fertile window, including rhythm method, cycle beads, basal body temperature, etc. Given the high incidence of anovulatory cycles in teens, Fertility awareness-based methods should be used with caution in this population, as ovulation cannot be predicted. Withdrawal, or removal of the penis from the vagina prior to ejaculation, and spermicides have typical use failure rates of greater than 20%, withdrawal at 22%, and spermicides at 28%. It is important to note that over half of sexually active teens have used withdrawal for contraception in the past and likely underestimate the failure rate of this method. Emergency contraception was mentioned earlier while introducing the copper IUD. Emergency contraception, otherwise known as EC, are the methods used to prevent pregnancy after unprotected intercourse, which may include assault, condom breakage or slippage, missed or late hormonal methods, or no method at all. EC includes the copper IUD and emergency contraceptive pills, or ECPs. There are 3 formulations of ECPs that can be used, and all work primarily by delaying or inhibiting ovulation. ECPs do not cause abortion or harm an already established pregnancy. Since ovulation may only be delayed for the cycle, a woman may become pregnant if she has unprotected intercourse in the coming weeks before her next menses. It is recommended by the AAP and the US SPR that appropriate patients be offered advanced prescriptions of ECPs and that ongoing contraception be addressed if ECPs are used. The newest formulation available is ulipristal acetate, an anti-progesterone, which was approved in 2010 for up to 120 hours. In a few studies, it has been shown to be more effective than levonorgestrel at and beyond 72 hours, and may be more effective than levonorgestrel for obese women. It is currently available by prescription only. Levonorgestrel is a progestin-only ECP and has been available as 1 or 2 pills since first approved in 1998. It is now available as 1 pill without prescription regardless of age. It is recommended to take the single or 2 pills as soon as possible after unprotected sex, as effectiveness declines over time. The USP method, an off-label use of COCs, requires taking multiple pills at once in 2 doses, which is not as effective as the other methods, and often causes nausea and vomiting. In addition to their contraceptive benefits, hormonal contraceptives have several non-contraceptive benefits that may relieve symptoms of patients not in need of contraception, or may provide added benefit while also providing contraceptive benefits. Dysmenorrhea affects up to 90% of young women and can be improved or alleviated with COCs, the implant, or the levonorgestrel IUD. Irregular cycles or heavy cycles, which are common with anovulation in young women, may be improved with levonorgestrel IUD, DMPA, COCs, or POPs. COCs have been also shown to protect against both ovarian and endometrial cancer, as well as ectopic pregnancy. CHCs, especially pills, may improve acne. Menstrual suppression may be desirable for life events, disabled patients, or for menstrual-related symptoms, and can be achieved with continuous use of CHCs, DMPA, implants, or the levonorgestrel IUD. Endometriosis, related pain may be alleviated with COCs, DMPA, implant, or levonorgestrel IUD. Extended or continuous use of CHCs may also improve premenstrual symptoms otherwise experienced without hormonal contraception or on cyclic regimens that have a 7-day hormonal-free interval. The next section we will be discussing is dual protection and its importance, especially among adolescents. While abstinence is the most effective way to prevent both pregnancy and STIs, we need to educate teens on how to prevent these outcomes if they are sexually active or are planning to be sexually active. Now that we understand the contraceptive methods that are available and their failure rates, let's discuss dual protection. Dual protection for those sexually active is the protection against both pregnancy and STIs using either a hormonal method, an IUD, or a condom, and consistently and correctly using condoms. Again, looking at typical use contraceptive failure rates, male and female condoms are in Tier 3 with failure rates of 18 and 21% respectively. While not highly effective contraceptive methods, male and female condoms have an extremely important role in healthy sexual behaviors. Consistent and correct use of the male latex condom reduces the risk for HIV infection and other STIs, including chlamydial infection, gonorrheal infection, and trichomoniasis. When male latex condoms cannot be used properly, a female condom should be considered. This graph shows age and sex-specific rates of chlamydia infection per 100,000 individuals in the U.S. population. Men are on the left and women on the right, stratified by age group. Rates of chlamydia in young women ages 15 to 19 are particularly high compared to teenage boys or compared to women of older age groups. For example, young women aged 15 to 19 have a rate of chlamydia infection over 4 times the rate of infection of their male counterparts. This graph shows how STI protection and pregnancy protection overlap. Most methods that confer good STI protection are not the most effective contraceptive methods, and most highly effective contraceptive methods do not provide STI protection. Since no method is good at both, it is important for those at risk for pregnancy and infection to use dual protection. Male condoms and LARCs provide the most effective combination. What guidance do we have regarding dual protection? We know that other contraceptive methods do not protect against STIs and HIV. The U.S. Medical Eligibility Criteria, or USMEC, and the AAP recommend correct and consistent condom use, either alone or with another contraceptive method, if the individual is at risk for STIs and HIV. The AAP states that condoms should be used by all sexually active adolescents, regardless if another additional method is used for contraception. Healthy People 2020 includes 2 goals to increase dual protection. The first is to increase the proportion of sexually active persons aged 15 to 19 years who use condoms alone to achieve dual protection. The second is to increase the proportion who use condoms along with a more effective contraceptive method to achieve dual protection. If our goal is to increase the proportion of teens using dual protection, we should understand where we are starting from. According to NSFG 2006 to 2008, only 20.8% of unmarried female teens use dual protection at last sex. 51.6% consistently used condoms in the previous 4 weeks. In this section, we will be discussing the U.S. Family Planning Guidelines. The objectives are 1. To become familiar with the U.S. MEC categories. 2. To focus on recommendations for use of LARC in teen population to be comfortable supplying teens with highly effective methods, and to introduce the U.S. selected practice recommendations and understand how it can help with contraception provision. So let's discuss the U.S. Medical Eligibility Criteria of 2016, or the U.S. MEC. Here is its cover from the document when it was published in the CDC's MMWR back in July of 2016. As we've already seen, contraceptive use is key for adolescents who are attempting to avoid unintended pregnancy. CDC's Division of Reproductive Health has been working to develop guidelines for the safe and effective use of contraception. The USMEC is one such guideline. It was first published in 2010 and later updated in 2016. Its main purpose is to give providers guidelines to determine the safety of contraceptives for women with certain medical conditions or characteristics. It contains guidance for 17 contraceptive methods and over 120 conditions. However, it is important to note that providers should always consider individual clinical circumstances when counseling patients about contraceptives. The USMEC uses a numeric scheme to provide the recommendations for specific contraceptive method and medical condition combinations. A 1 means there is no restriction for the use of the contraceptive method for a woman with that given medical condition. For example, copper IUD use among women with hypertension. A 2 means that the advantages of using the method generally outweigh the theoretical or proven risks. A 3 flips the risk-benefit ratios and says that the theoretical or proven risks of the method usually outweigh the advantages, or that there are no other methods that are available or acceptable to the women with that medical condition. Finally, a 4 means that there is an unacceptable health risk if the contraceptive method is used by a woman with that medical condition. The USMEC can be used in several ways. In addition to the document itself, we have also created many useful provider tools that quickly summarize the guidelines. We will be discussing these tools in the coming slides. The CDC Contraception webpage for healthcare providers is provided on this slide. On the USMEC page, you can find the link to the original publication in CDC's weekly Morbidity and Mortality Weekly Report, or MMWR. In addition, the page now includes an easy click-through version of the MEC. The updated CDC Contraception app for Apple and Android smartphones and tablets now includes the MEC in a user-friendly format, with easy navigation between the MEC and SPR. It also easily links to other CDC guidance, such as STD treatment guidelines. This updated app is available for download through our website. Many providers who use smartphones or other clinical references find this to be the easiest way to access guidelines in everyday practice. CDC also has printed and laminated MEC quick reference summary tools, which can be ordered or printed from our website. These include a color-coded summary chart and handy pocket wheel, which many providers find to be very useful. This table shows an example of the numeric scheme in the MEC, specifically for the condition of age. The number 1 indicates there is no restriction for use. The number 2 indicates that the method can generally be used by the patient. The number 3 indicates that the method generally cannot be used by the patient. And the number 4 indicates the method should not be used by the patient. For the condition of age, recommendations for contraceptive use may differ depending on the age subgroup and which method is desired. For POPs, the implant and barrier methods, recommendations are the same for all ages. However, for CHCs, the injection, and IUDs, the recommendations vary depending on the age of the patient. These recommendations may differ for teens with certain medical conditions. The MEC can be consulted for full recommendations. There are many myths and misconceptions that commonly prevent women from accessing effective contraceptive methods. 3 such myths are noted here. Evidence-based recommendations help dispel these myths. The first myth is that IUDs cause pelvic inflammatory disease and infertility. But the fact is that chlamydia and gonorrhea are what cause PID and can lead to infertility, not IUDs. The second myth is that DMPA causes fractures. The fact is that small amounts of bone mineral density is lost during use, but ends up being regained after discontinuation. The last myth is that contraceptive pills cause cancer. The fact is that contraceptive pills actually protect against 2 cancers, ovarian and endometrial cancer. Okay, let's discuss an example clinical scenario. A 16-year-old female walks into your office. She is healthy, nulliparous, and is currently using condoms, but wants a more reliable method. Which of the following options are available to her? Like previously mentioned, there are various myths and misconceptions about IUD use in adolescents. These concerns are real and should be addressed with reassurance that evidence-based recommendations tell us that the IUD is generally safe for use in adolescents. There is concern regarding an increased risk for expulsion, which has been shown in some studies, and thus the recommendation for IUD in women younger than 20 is a category 2. Risk of infertility has been shown to be associated with gonorrheal and chlamydial infection, not due to age. Risk of STIs is another common concern for this population and IUD use. Those with an active infection should not have an IUD placed. There has also been a lot of concern regarding use of DMPA in adolescents, specifically regarding loss of bone mineral density and weight gain. There is no evidence that DMPA use increases fracture risk in adolescents, and it is unclear how bone mineral density measures are associated with future fractures in adolescents. We do know that bone mineral density is lost in small amounts during DMPA use in women, including adolescents, and we also know that the bone mineral density is regained after discontinuation. As for obesity, obese adolescents using DMPA may be more likely to gain weight compared to non-obese users, and obese users of other methods. Thus, DMPA is a category 2 opposed to a category 1 for women less than 18 years old. Back to scenario 1. From what we just learned, the correct answer would be all of the above. In addition to these methods, it is important to also encourage continued condom use for dual protection. Okay, let's discuss a second scenario. An 18-year-old G1P0 pregnant teen walks into your office and requests counseling for postpartum family planning. She is not planning on breastfeeding. What options are available to her immediately postpartum? Let's look at the recommendations associated with her postpartum non-breastfeeding status. During the first 20 days postpartum, CHCs are a category 4, meaning they should not be used given high risk of venous thromboembolism, or VTE. For 21 to 42 days after delivery, the recommendation acknowledges that there may still be some safety concerns, but this depends on presence of other risk factors. With risk factors, CHCs are a category 3, meaning that risks generally outweigh benefits. The asterisk next to the 3 means there's a clarification to this recommendation in the guidance. The clarification states that depending on the other risk factors present, this might be a 4, but without risk factors, it would be a 2, meaning that benefits generally outweigh risks. Beyond 42 days, CHCs are a category 1, meaning there are no safety concerns based on postpartum status. Progestin-only methods are a category 1 for all time periods postpartum among non-breastfeeding women. Now let's take a look at the recommendations for IUDs. IUDs have different subgroups compared to CHCs and progestin-only methods explored on the previous slide. Rather than recommendations based on days after delivery, recommendations are based on whether the IUD is placed within 10 minutes after placental delivery, or from 10 minutes up until 4 weeks after placental delivery, or even at 4 weeks or more from delivery. All of these time frames are category 1 or 2, so are safe or generally safe to use among women of any age. Postpartum sepsis is a category 4, meaning do not use. Let's go back to the scenario and discuss the options. Given the US MEC recommendations, she can safely use either IUD or progestin-only method immediately postpartum. Depending on other VTE risk factors, she may also use combined hormonal methods at 21 days or 42 days postpartum. In addition, remember to encourage condom use for dual protection. Let's discuss one last scenario in this section. A 16-year-old nulliparous female with heavy cycles and dysmenorrhea presents with her mother saying she is missing school at the start of most of her periods. She is sexually active with her boyfriend using condoms. What options are available to her? If you said all of the above, then you are correct. According to the US MEC, she can safely start any of the methods above for contraceptive use. However, All methods other than the copper IUD have been shown to be beneficial to women who have heavy cycles and dysmenorrhea. In addition, remember to encourage continued condom use for dual protection. In this next section, we will be discussing the U.S. Selected Practice Recommendations. The objectives are 1. Become familiar with the U.S. SPR categories. 2. Focus on recommendations for use of LARC in teen population to be comfortable supplying teens with highly effective methods. And 3. To introduce the U.S. Selected Practice Recommendations and understand how it can help with contraception provision. The U.S. Selected Practice Recommendations for Contraceptive Use, or U.S. SPR, was first published in 2013 and updated in 2016. This is a screenshot of the cover of the published MMWR. The U.S. SPR is a companion document to the U.S. MEC, and like the U.S. MEC, was adapted from the original World Health Organization versions. The intention of the U.S. SPR is to provide evidence-based recommendations for common yet controversial contraceptive management questions, such as issues listed here. The U.S. SPR is intended for use by health care providers in counseling patients about method use, as well as management of certain problems with use. The U.S. SPR is not a comprehensive textbook, does not answer who can safely use methods like the U.S. MEC, does not provide rigid guidelines to follow, and does not address guidance for well woman care. The recommendations in the U.S. SPR apply to women of all ages, including adolescents. Adolescents in particular may face certain barriers to initiating and using contraception effectively, including challenges in accessing supplies and difficulties with adherence. The goal of the U.S. SPR is to reduce these barriers by providing guidance for how all women, including adolescents, can initiate methods easily and continue use effectively. The U.S. SPR is arranged by contraceptive method, and accompanied with each recommendation is a comments and evidence summary. Throughout the document there are tables, flowcharts, algorithms, and quick bullets to simplify the actual recommendations. In addition to the document itself, we have also created many useful provider tools that quickly summarize the guidelines. We will be discussing these tools in the coming slides. The CDC Contraception webpage for healthcare providers allows for online access to the SPR, similar to the MEC. On the US SPR page, you can find the link to the original publication in CDC's Morbidity and Mortality Weekly Report, or MMWR. In addition, the page now includes an easy click-through version of the SPR. The updated CDC Contraception app for Apple and Android smartphones and tablets now includes the SPR in a user-friendly format, with easy navigation between the SPR and MEC, as previously mentioned. It also easily links to other CDC guidance, such as STD treatment guidelines. This updated app is available for download through our website. Many providers who use smartphones for other clinical references find this to be the easiest way to access the guidelines in everyday practice. CDC also has printed and laminated SPR summary charts, which can be ordered or printed from our website. Flowcharts for the SPR include management strategies for common issues such as how to be reasonably certain a woman is not pregnant, when to start contraception, how to manage late or missed combined hormonal contraceptive methods, management of an IUD with pelvic inflammatory disease, and management of bleeding irregularities while using contraception. Posting the colorful flowcharts in staff work areas can help to raise awareness and use of the guidelines. Okay, let's discuss some clinical scenarios. This scenario addresses the issue of when to start a contraceptive method. A 16-year-old female comes to the office desiring contraception and decides she wants the implant. When can she start? There are several barriers to initiating contraception, which increases the time a woman is at risk for unintended pregnancy. Some examples of these barriers are waiting for next menses to start the method, or coming back for another visit, or the need to fill a prescription. Quick start is the start of a contraceptive method when a woman requests it. This may reduce the time a woman is at risk for pregnancy and may reduce barriers to starting a method. The US SPR provides guidance both within the document and summarized in a user-friendly chart to guide providers on when to start a method and how to counsel patients on backup needs for all methods. Any of the methods can be started at any time if a provider is reasonably certain that a woman is not pregnant. For the implant, if it has been more than 5 days since last cycle, she will need to use a backup method or abstain from sexual intercourse for 7 days. For women in other situations that may not have a last menstrual cycle to refer to, guidance on how to initiate methods is also available. These situations include for women who are amenorrheic, postpartum, post-abortion, or are switching from another method. These recommendations can be found under each contraceptive method in the When to Start section. Okay, now let's return to the scenario. The correct answer to this question is that the contraceptive method can be started any time if reasonably certain the patient is not pregnant. If it has been more than 5 days since menstrual bleeding started, she will need to abstain from sex or use additional contraception for the next 7 days after starting her combined pills. This slide refers to the previous scenario, but now we will discuss how to be reasonably certain that the teen is not pregnant. Some providers may question whether or not they should do a pregnancy test to rule out pregnancy, and may also question if a pregnancy test is enough. The evidence shows that pregnancy testing does have limitations. Pregnancy detection rates vary depending on the sensitivity of the test and the timing of testing with respect to missed menses, last intercourse, or last pregnancy. False negatives may occur with recent intercourse, while false positives may occur after recent pregnancy. This box is taken directly from the US SPR and discusses the criteria that need to be met in order for a provider to be reasonably certain that a woman is not pregnant. If the patient has no symptoms or signs of pregnancy that meets any of the following criteria, then a provider can be reasonably certain she is not pregnant. Several studies have been conducted comparing the negative predictive value of this criteria with the pregnancy test. These studies all showed a negative predictive value of 96% to 100%. This means, of the 100 who had a negative result according to the pregnancy checklist, 96 to 100 of them were not pregnant according to a pregnancy test. This indicates that this pregnancy checklist criteria can be used to accurately rule out pregnancy and safely start contraception. Back to the clinical scenario. After discussing, the answer is, if she has no signs or symptoms of pregnancy and fulfills one of the criteria, a provider can be reasonably certain that the woman is not pregnant. This slide is a continuation of the previous scenario, but now we will discuss if we need to do any exams or tests before she starts. The US SPR also provides recommendations that address exams and tests needed prior to starting a woman on a method, as unnecessary tests may create barriers to contraceptive initiation. For example, a pelvic exam itself may be a barrier to women getting contraception, especially adolescents, if they are not willing to participate in the exam. Waiting for test results may be another barrier that delays contraceptive use. The US SPR provides recommendations that address exams and tests needed prior to starting a woman on a contraceptive method. These recommendations are categorized into 3 classes. Class A are essential and mandatory for a given method. Class B exams and tests contribute substantially to safe and effective use, but implementation may be considered within the public health and/or service context. Finally, Class C does not contribute substantially to safe and effective use of the method. This slide replicates the summary chart in the US SPR for all contraceptive methods and commonly performed screening exams and tests. Here you can see that there are very few Class A exams and tests, none of which are listed under implant. The blood pressure recommendation before initiating combined hormonal contraceptives is Class A, accompanied by the statement. In cases in which access to health care might be limited, the blood pressure measurement can be obtained by the woman in a non-healthcare setting and self-reported to the provider. A pelvic exam is essential before placement of an IUD or to fit a diaphragm or cervical cap, but is not necessary for any other method. Pelvic examination is not necessary before initiation of the implant because it does not facilitate detection of conditions for which hormonal contraceptives would be unsafe. A systematic review examined 2 case control studies comparing delayed and immediate pelvic examination before initiation of oral contraceptives or DMPA. No differences in risk factors for cervical neoplasia, incidence of STIs, incidence of abnormal pap smears, or incidence of abnormal wet mounts were found. The highlighted area shows that there is a footnoted recommendation for measuring weight and calculating body mass index, or BMI, before initiation of methods. Weight, or BMI measurements, are not necessary before starting the implant. For implant initiation, the recommendation for checking weight is a comment stating, weight measurement is not needed to determine medical eligibility for any methods of contraception because all methods can be used, or generally can be used, among obese women. However, measuring weight and calculating BMI at baseline might be helpful to monitor any changes and counsel women who might be concerned about weight change perceived to be associated with their contraceptive method. Going back to the clinical scenario, the correct answer would be no. There are no exams or tests that are necessary before initiating the implant. Measuring weight and calculating BMI at baseline might be helpful to monitor any changes and counsel women who might be concerned about weight change perceived to be associated with their contraceptive method. Now, what if she decided to get a levonorgestrel IUD instead of an implant? Do any of the previous steps change? The first question was, when can she start? She can start any time as long as the provider can be reasonably certain that she is not pregnant. The criteria to answer the second question, how to be reasonably certain that she is not pregnant, have also been reviewed. Finally, the third question asks if any exams or tests need to be done before initiating. Let's explore the chart on the next slide for the answer. There are a few exams and tests that are necessary before starting contraception. A pelvic exam is essential before placement of an IUD. Therefore, it is the only Class A exam or test listed for an IUD. Measuring weight and calculating BMI at baseline might be helpful to monitor any changes and counsel women who might be concerned about weight change perceived to be associated with their contraceptive method. For IUD use, the US SPR recommendation states that most women do not require additional STD screening at the time of IUD insertion. If a woman with risk factors for STDs has not been screened for gonorrhea, and according to the CDC's STDs treatment guidelines, screening can be performed at the time of IUD insertion, and insertion should not be delayed. Women with current purulent cervicitis or chlamydial infection or gonococcal infection should not undergo IUD insertion. Therefore, for an IUD, a bimanual exam is necessary before placement. STD screening should also be performed according to CDC STD treatment guidelines. That means annual screening for all sexually active females aged less than or equal to 25 years for C. trachomatis and N-gonorrhea. Women aged less than 25 years are at the highest risk for gonorrhea infection. For IUD use, the U.S. SPR recommendation states that most women do not require additional STD screening at the time of IUD insertion. If a woman with risk factors for STDs has not been screened for gonorrhea, and according to CDC's STD treatment guidelines, screening can be performed at the time of IUD insertion, and insertion should not be delayed. Women with current purulent cervicitis or chlamydial infection or gonococcal infection should not undergo IUD insertion. Let's discuss this next scenario. This one addresses use of emergency contraception. A 17-year-old female had unprotected intercourse 4 days ago and is worried about pregnancy. What are her emergency contraception options? Currently, there are 4 options for emergency contraception, or EC. The copper IUD and 3 types of emergency contraceptive pills, or ECPs. The 3 types of pills include ulipristal acetate, or UPA, levonorgestrel, or LNG, as well as combined estrogen and progestin oral contraceptive pills. All options may be utilized within 5 days of unprotected sexual intercourse. The copper IUD should be placed within 5 days of the first act of unprotected sexual intercourse. Since these options are not all the same, how can you help her choose the best option for her? The evidence shows that copper IUDs are highly effective as emergency contraception and can be continued as regular contraception if that is what she desires and she is willing to come in for a visit. UPA and LNG have similar effectiveness when taken within 3 days after unprotected intercourse, while UPA may be more effective between 3 and 5 days after unprotected sex. UPA may also be more effective than LNG for women who are obese, according to one study. The combined regimen, also known as USP method, is less effective than the other 2 ECPs and is associated with more frequent side effects, particularly nausea and vomiting. Going back to the scenario, this patient has 4 options for emergency contraception. There are no conditions for which she cannot use ECPs. For emergency IUD use, she needs to meet the medical eligibility criteria for regular IUD insertion. Now let's say this patient has decided to take UPA, but is unsure when she can start regular contraception after taking ECPs. Let's see what the SPR recommends. Resuming regular contraception after ECPs requires consideration of the risk of pregnancy if ECPs fail, and the risk of unintended pregnancy if contraception initiation is delayed until the next menstrual cycle. There is no concern with starting or resuming hormonal contraception concurrently with estrogen or progestin ECPs because these methods do not contain an anti-progestin and have not been shown to have negative effects on an early pregnancy. Data on when to start contraception after UPA ECPs is limited to pharmacodynamic data and expert opinion. One pharmacodynamic study raised concern for decreased effectiveness of UPA if hormonal contraception was started the next day, specifically less ovulation suppression. Therefore, after levonorgestrel or combined ECPs, any regular contraceptive method can be started immediately. The woman should abstain from intercourse or use backup for 7 days and take a pregnancy test if she does not have a withdrawal bleed within 3 weeks. For women using UPA, she should resume or start hormonal contraception no sooner than 5 days after UPA due to possible concerns of decreased effectiveness of UPA if hormonal contraception is started sooner. This may require a repeat visit, depending on her method choice. Non-hormonal contraception can be started immediately. Abstain from intercourse or use backup for 7 days after starting contraception. So the answer to this scenario, if she is taking UPA, is that she can resume hormonal contraception after 5 days. However, if she decided to take another type of ECP, the answer would differ. If she took an levonorgestrel or CHC ECP, then she should start any method immediately. Regardless, she will need to abstain from sex or use a barrier contraception method until she has been on the new method for 7 days or until her next menses, whichever comes first. So some of the take-home messages from this presentation. Rates of adolescent pregnancy in the U.S. are decreasing, but remain high. Adolescents who are at risk of unintended pregnancy need access to highly effective contraceptive methods. Adolescents are eligible to use all methods of contraception. There are no contraceptive methods that an adolescent cannot use based on age alone. Long-acting reversible contraception, or LARCs, including IUDs and implants, may be particularly suitable for many adolescents. Dual protection should be encouraged for adolescents. Most women, including teens, can start methods of contraception anytime, including on the day of the visit, as long as the provider is reasonably certain that the woman is not pregnant. Few, if any, examinations or tests are needed before starting a contraceptive method. Bleeding problems are a major reason for contraceptive discontinuation. Recommendations on anticipatory counseling before starting a method and management of bleeding problems are provided. Adolescents should be advised to return at any time to discuss side effects or other problems, if she wants to change the method being used, and when it is time to remove or replace a contraceptive method. Otherwise, routine follow-up is generally not required. Many options for emergency contraception are available, including the copper IUD and different formulations of pills. Regular contraception should be started after emergency contraceptive use. More teen pregnancy information can be found at cdc.gov, then clicking on the T from the A to Z index. Teen pregnancy is then listed on the left-hand side of the following page. Here's a screenshot of the CDC teen pregnancy webpage. The CDC contraceptive guidance can be found at the link on this slide. Here are some additional resources that may be useful for keeping up to date on guidance and statistics. Thank you for joining us for this continuing education presentation on teen pregnancy prevention.